that by the end of this meeting we would have achieved, and that is why the engagement has to take place today. So welcome everyone, and I give it back to the MC.
Thank you so much. Gladys, let's appreciate Gladys, please. So, Madam PS, just as we invite you now to come to the podium, allow me to acknowledge the COG, the WHO, UNICEF, IOM, AMREF, Africa CDC, Interreligious Council for the state, the MOH team, and the IMS structure. So with this now, members, allow me with a lot of humility and say all protocol observed, and to be able to invite our peers to address us. Madam PS, please. One more time. One more time again for the PS. Let's usher the PS, please, as she comes in. Can be upstanding as we usher the PS to come, please.
Please get seated. Limo, I did not know you are a politician. Your posture does not present like that, but all in all, WR, UNICEF, IOM, county government, members of the fourth estate, Ministry of Health, a very good morning. Good morning. Happy New Year. Happy New Year. This is the very one meeting that we have started with this year. And this is just an indication that we are very keen on our prevention, promotion, and protection agenda as a ministry, as a country, and equally jointly with our partners. So I want to welcome you all this morning, and I'm pleased to also be here for this very, very important media breakfast meeting where we come together to discuss a public health concern that has drawn attention across the globe and right here in our beautiful country, and to discuss the response to this Mpox outbreak, which has been ongoing since the outbreak was first declared in July 2024. As we are very well aware, Mpox is a viral disease that can be transmitted from animals to human, and in some cases from human to human. As a country, we are equally very committed to ensuring that we respond effectively to mitigate any potential public health risk to our citizens that may be occasioned by any outbreak, not just by Mpox, but any outbreak. Regarding the current situation in Kenya, ladies and gentlemen, it is important to note that Mpox remains a very, very big threat, not just in Kenya, but the East African region, and in our country at large. We have seen in the past 1 week, we have confirmed 5 new cases, 3 of which were reported one case, Taita Taveta, 1 case, 9th of January 2025. The most recent cases, as reported on 21st January 2025, have been reported from Busia, 2 cases, and Kilifi, 1 case. This brings the total number of Mpox cases in the country to 36 from across 12 counties. The highest number of cases by counties is Nakuru County. Nakuru County has reported 10 cases. Mombasa, 8 cases. Busia County, 3 cases. And other counties reporting are Nairobi, Kajiado, Bungoma, Taita Taveta, Kericho, Kilifi, with 2 new cases each, as well as 1 case each from Makueni, Kiambu, and Uasin Gishu. You need to note that Nakuru seems to be a very unique county, and it's like the apex, the meeting point of very many other people coming from different counties. If you have an entry from Malaba, you have to pass through Nakuru. If you have an entry from right from Uasin Gishu, that road, they're coming from Mombasa all the way through Nairobi, you pass through Nakuru. And hence, you can see the number of cases are quite high. Equally, Mombasa is like the destination point. Anybody coming from Nairobi, going all the way to Mombasa, and probably also coming from Tanzania. The Ministry of Health has put in place a robust surveillance system to quickly identify any potential cases. And this includes close monitoring of travelers, especially those coming from counties where there is an active outbreak, and the provision of timely information of healthcare providers and the general public across the country. The Ministry of Health, again, has taken proactive steps in coordination with key stakeholders, among them who are in the room, that is the World Health Organization, UNICEF, and other partners who have come in handy. We have IOM, we have CDCs, and all the other partners to ensure that we have the necessary capacity to respond. This includes strengthening our healthcare system, providing our healthcare workers with the necessary training and personnel protective equipment, and ensuring that diagnostic tools are readily available in our laboratories. I know we have heightened and enhanced the capacity in our laboratories, and unlike before, and especially during COVID, when we could send samples all the way to even South Africa, this time round with Mpox, we have been able to test each of the samples in our laboratories. And those must be lab people. And you're doing a very good job. They are really, really doing a good job. We have also initiated public awareness campaigns through community engagement with key populations, social and mass media, and dissemination of information, education, and communication materials to educate the general public on how to protect themselves from the disease, and key preventive measures, including proper hand hygiene, as well as enhancing hygiene in hospitality industry, among areas or among others that are vital in controlling the spread of Mpox. I know the last quarter of last year, we were very busy across the country. We met hoteliers, we met truck drivers, their association, we met main key stakeholders who are likely to be giving services, and maybe will come into contact with individuals, and there is the high risk of infection. The role of the media, and that is why we are having this meeting this morning, very critical. As we work on these preventive measures, I would like to take a moment to acknowledge the critical role that the media plays in public health communication. You are very, very instrumental, and especially in the public, that the public receives timely, accurate, and reliable information. There are very many myths that you find out here, and it is the role of the media to accurately report on information, and there should be one source of that information. It should come from the Ministry of Health or stakeholders who are who have authority to speak in regards to matters health. so that as we talk to the public, we can array the fears that they have, and we can also give information on what they need to do to prevent themselves from further infection. So your efforts in educating the public, countering misinformation, and amplifying key messages are invaluable. You know, a simple message like, please wash your hands. It may not even be connected to Mpox as a disease, but you know, the action in itself will help us prevent further infection from the public. So it is through your partnership that we will be able to effectively communicate prevention messages and encourage individuals to seek health care if they suspect they have been exposed to the virus. I want to urge you, members of the Fourth Estate, that you continue working very closely with us and share accurate and responsible information. I have always said we cannot put anything political in matters health. And as we try to roll out universal health coverage, I would want to ask the media that if you have anything political, please do not report on matters health. Let us work together. If there is a problem in this country, it will affect your mother, it will affect my mother, it will affect the people you love most, it will affect people you work with. Therefore, we must work together to make sure that the members of public get the right information. We are looking ahead as a ministry, and we are not going to stop on issues awareness. The ministry is also actively preparing for all scenarios, including the possible emergence of more cases. We are in regular communication with global health bodies and our regional counterparts to stay updated and on development and best practices, because diseases have no boundaries. We cannot stop any. We can only prevent ourselves and make sure that we enhance our surveillance and equally the screening, and especially at the border points. Now that the schools are open, the Ministry of Education again is working very closely with the Ministry of Health to make sure appropriate measures are also put in place to strengthen and including the infection prevention and control measures and on water and sanitation hygiene. As a ministry, last year we rolled out a program that will see us enhancing issues to do with personal hygiene, basic hand washing, use of a handkerchief, should you be sneezing, environmental hygiene, issues to do with vector-borne diseases that are preventable, malaria, sleeping under a net, you know, environmental hygiene, draining of water, stagnant water, issues to do with the diarrhea, you know, preventable diseases that can be prevented through environmental hygiene, water and sanitation. In this country, we still have about 15 counties that practice open defecation, and eradication of the same is our #1 priority. Just ensuring that every household has at least a toilet or a latrine, so that we avoid people going into the bushes, defecating, and when the rains come, it will affect each one of us, whether you have the latrine or you don't. Therefore, to further strengthen the ongoing prevention measures, the ministry is set to roll out the Mpox vaccination, targeting high-risk groups such as contacts of confirmed cases and population that are most at risk of contracting the disease. The media plays a critical role in the key intervention, and we therefore request that you provide accurate factual information to also curb Mpox vaccination infodemics. I will reiterate and say, as much as we are talking about prevention, promotion, protection, should you get unwell, where do you run to? And that is why the ministry equally has introduced the Social Health Authority, because our population will require to go to a facility where you can be treated at any given time. And what is going to cover you? You need an insurance cover. And the Social Health Authority comes into play at this particular time. Because if issues of prevention, we've gone past that mark and you're unwell, therefore you will require to register. Ask the masses to register to the Social Health Authority. Ladies and gentlemen, I would want to state that it is very, very important to note that NHIF would only cover 20% of our population, whereas the Social Health Authority teams to cover 100% of the population of Kenya. And we are riding on the Article 43 of our Constitution that states that every Kenyan deserves quality education, quality health. Therefore, riding on that, every child, any grown-up, will require to register to the Social Health Authority. Before I conclude, ladies and gentlemen, allow me to make a few remarks around the Marburg virus outbreak, which was confirmed in our neighboring country of Tanzania in an area called Kagera. And the outbreak was confirmed on 20th January 2025. Although we had received an alert on the possibility of an outbreak several days earlier, and on the basis of that, we already have heightened our level of alertness as a country. And Kenya is classified as being a high risk of Marburg virus disease outbreak, primarily due to the fact that Kagera region is a transit hub in the region, with significant movement of the population to Rwanda, Uganda, Burundi, and Democratic Republic of Congo, and Kenya. Therefore, as I mentioned, I would like to assure you that the ministry is on high alert, and surveillance has been enhanced at all points of entry into Kenya. In addition, the Ministry of Health, on the 21st of January this year, we issued a press release on the issue of to the public, which you all received probably, as well as an advisory to the counties informing them of the Marburg virus disease outbreak. A readiness assessment in the progress at the national level and in high-risk counties in collaboration with the Council of Governors. Additionally, we are working with all the other MDAs. We have already sent information, our partners, stakeholders, towards developing a robust national emergency preparedness and response plan. And this touches a whole of government approach, a whole of society approach. So each one of you will be expected to have an input in the response plan preparedness to ensure we do not leave gaps as we move forward. And this will ensure that as a country we are adequately prepared to respond to any outbreak in the event such a situation arises. Ladies and gentlemen, I want to emphasize that while the threat of Mpox is real, the commitment is to. We are also committed to ensure that we give the very best for the citizens of this country. The government of Kenya is committed to safeguarding the health of all Kenyans and in ensuring we are well prepared to disease outbreaks and other health emergencies. In this regard, we have made great strides to the response of this outbreak and preparedness for the possible Marburg virus outbreak, and with continued vigilance, effective implementation of the recommended public health interventions and the collaboration of all sectors, including you, the media, I am very confident that we will win against these public health challenges. I want to congratulate the healthcare workforce who have always been at the front line whenever there are these such outbreaks. And I want to call upon all public health officers to take on the gloves and wear their best suited gears so that we can go out there and ensure that surveillance is done. Our surveillance teams, both at the county level and the national government, this is the time to show your prowess. I know you're doing a great job, but I will keep insisting that we can still do better. To the lab people, thank you, thank you, thank you. Give us the most accurate results so that we are able to treat people as they come. Thank you very much, and may God bless you all. I am looking forward to our continued partnership. WR, you very well know, SDG 17 talks about partnerships. We can't do this alone. We have to come together every now and then. There are those areas that you have a strength, and there are those areas that the government will truly come out strongly. And as the government of Kenya, we are on that lane of saying prevention is better than cure. So let's get prepared. Asanteni sana.
Please, can we have a better way of appreciating our PS? One more time. Thank you, Madam PS. I feel encouraged on the 23rd of January. Thank you for that. So with your permission, Madam PS, allow me to invite a few other people who have really been assisting us from the agencies. They have done a lot through your office. So as I invite, allow me to acknowledge also the US CDC in the room and also the Africa CDC. So I will start by inviting our colleague from IOM, Faisal. Faisal is the head of program and policy. And if you don't mind, allow me now to invite him officially. Faisal.
Honorable Principal Secretary Health Mary Muthoni Murioki, kindly allow me to write down the protocol that has already been established, but also want to acknowledge the presence of sister UN agency representatives and delegations from Government of Kenya and public and private sector. Hamjambo. My name is Faisal, Sharif Faisal. I'm the Head of Programs and Deputy Country Director of IOM Kenya. And it is my honor to speak to you today. PS very eloquently outlined the extent of the disease that we as a country in Kenya, but also in the region, are addressing and fighting. PS, you mentioned that it has to be a whole of government and whole of society. I also want to add that it has to be a whole of region approach, because you mentioned that the disease doesn't know any geographic boundary. So in July 2024, the Mpox outbreak was announced. IOM, with support from the government of Republic of Korea, was able to redirect some of our existing funding to respond to the Mpox outbreak. And in collaboration with our sister agencies, World Health Organization and UNICEF, and of course, with the Ministry of Health and under the leadership of PS and her team, we have been able to support 11 points of entry to capacitate the officials and strengthen the equipment and infrastructure, including Jomo Kenyatta International Airport in Nairobi, Mombasa, land crossings in Busia, and so on. We have trained over 900 officials, both health and non-health related technical officials, in strengthening their capacity. PS, as you're mentioning, some of the basic hygiene practices of washing hands and some of the messaging that we're seeing around the room today, these are extremely critical to fight this outbreak. So in response to that, we have also been able to produce over 10,000 IEC materials to disseminate these public health warnings and awareness raising messages to the populations of Kenya. So we are extremely proud of our collaboration, and I'm also very happy to announce that we just received some additional funding from the United States government to channel towards responding to COVID and, Mpox and Marburg. So again, PS, under your leadership and with the support of your team and our sister agencies, WHO and UNICEF, will be working together. And as a country, as a global nation, we fought something as difficult as COVID-19 together. So I'm confident to say that we'll be able to succeed against challenges like Mpox, Marburg, and any additional public outbreaks to come. With that, kindly allow me to stop here. Thank you so much.
Thanks so much, Faisal. One more appreciation to Faisal, please. With your permission, Madam PS, as I invite Africa CDC, let me acknowledge my boss, Dr. Grace, also. She has given me the power for a few minutes. So thank you, Dr. Grace and Dr. Sultani. So answer from Africa CDC, and then be followed by UNICEF, Luigi.
Ministry of Health and the esteemed leadership present here, Madam PS, DGG, Dr. Sultan, the IM, Director of Public Health. The efforts that are being done by all this critical outbreak, that's Mpox, complemented with other threats, the Marburg, and at Africa CDC, the collective leadership and unwavering advocacy and tireless efforts in combating the Mpox outbreak are truly commendable. Your commitment to ensure the safety and security and well-being of Kenyans and the entire African continent is commendable and inspiring. Africa CDC stands in solidarity with Kenya and reaffirms in this through continued collaboration, effective communication, and multi-sectoral approach, we effectively control this outbreak and safeguard the health and well-being of the communities. And we are keen that we will support all the pillars, including the emerging immunization of this Mpox disease, and we will continue supporting the government. Thank you.
Thank you so much, Hensa. Please let's appreciate him. Thanks. So as I invite Luigi from UNICEF, we'd like also to prepare. We have a special team from the long distance drivers and conductors. Where are you? Yes, please, we'll give you a chance to come after, no? We'll give you a chance after him. So Luigi, karibu sana Luigi. Thank you.
A very good morning, everyone. A pleasure being here, and I'm also extending wishes of a Happy New Year on behalf of UNICEF. Speaking now to Madam PS has just left us, and so has the WR, but I think under their leadership, and thanking to all the officials from the Ministry of Health, from other ministries, to the media here and other UN agencies. It's a pleasure being here. Let me start by extending on our behalf the congratulations to the government and to the people of Kenya, including each and every of you in this room, for having managed to date to keep a very serious threat of today. The caseload in the region is very high of Mpox, and Kenya to date, as you just heard, is at 36 cases. So I think my first point is, as diseases are global and the region is under we need to continue as a country to keep high alert on Mpox, as well as on other risks that will keep coming. We are more and more exposed to acute events, which can be outbreaks or other emergencies, and I think the role of all of us is going to be crucial. And therefore, which is what brings us here today, the role of the media is essential. So I wish to thank each and every of the media who are here and those who are not present perhaps today for their effort in joining hands everywhere through the country with different and through different means to reach out to the population with and simple, understandable, digestible information about diseases and outbreaks. And before that, also about health. As UNICEF, we are here joining hands with many partners under the leadership of the Ministry of Health for a very simple reason. Disease do not spare children. And as a United Nations Children Fund, we are here to help promoting and protecting the rights of children. And these outbreaks, as any other outbreaks, of course, especially in a country like this, where a vast majority of the population is about children and adolescents, needs a clear focus and attention on them and on their needs. To date, since the onset of this outbreak, of Mpox outbreak, we have joined hands with the government, with WHO and other partners, essentially to facilitate and support actions along three streams: the health response to the pandemic, but also the risk communication and community engagement, which is at the core of the day today for all of us, and actions related to water, hygiene, and sanitation. So along these three pillars, we have managed to mobilize resources and support the counties that have been identified by the Ministry of Health as the high-risk counties. I will not go into the details. I just want to say we stand here, we continue standing here. I would like to thank today the MasterCard Foundation for helping UNICEF to leverage resources to date to support the government of Kenya in its response. We will continue mobilizing efforts and resources as required as this outbreak continues, but also in anticipation of other health risks and hazards that may come to the country. A final word on the role of media. You have seen it on slides, you have heard it from the previous speakers. Your role is critical every moment, every day, first of all, in keeping the guard high. People may think that with 36 cases, the risk is minimal, and it's not. So the first point is keep people informed about what is happening. You get all access to information from the ministry. Please do help share the correct information, and as you heard, tackle the loads of misinformation that circulate in many formal and informal ways. My last ask, and then I will close it, is as you work as media, please do not forget that children and adolescents are not only a target for your communication, they are possibly the most powerful weapon you have to promote communication. They absorb, they learn, they understand, and they spread through their own behavior messages in their community. So engage them as you work as media into promoting communication about health and outbreaks in the country. I would stop it here, and thanks again to all, and again wishes of a happy 25. Thank you.
Thank you, Luigi. Please, one more time, please, to appreciate Luigi. It's my honor and pleasure now to invite WR, Dr. Diallo, from WHO Country Office. As he comes in, we'll have 2 speakers, then we go straight to the presentations. Dr. Diallo.
Dr. Sultani, Dr. Grace, county government representatives present, distinguished members of the media, esteemed partners, distinguished guests, all protocol observed, ladies and gentlemen, good morning. I hope you all had a good start to the new year. So allow me to also wish you a happy new year. Ladies and gentlemen, it is both a privilege and an honor to address you today at this important media sensitization meeting on Mpox. Your presence here demonstrates the crucial role the media plays in safeguarding public health and combating misinformation, which is critical in times of health emergencies like the one we face today. As you're aware, Mpox remains a public health challenge globally, continentally, and nationally. Mpox has not only impacted individuals and families, but also exposed the vulnerabilities in the healthcare systems, underscoring the importance of sustained investments in preparedness and response across the whole region. In Kenya, our efforts have been focused on prevention, containment, and raising awareness to protect the health and well-being of all Kenyans. The Ministry of Health, in collaboration with WHO and our partners, UNICEF, IOM, Africa CDC, and others, have raising awareness, managing misinformation and disinformation, sourcing vaccines, building capacity for health workers, and community sensitization. Even so, while strides have been made in controlling the disease, we cannot afford complacency. One of the most persistent challenges we face is the battle against misinformation and disinformation. Misleading information about Mpox has the potential to erode public trust, delay health-seeking behaviors, and fuel stigma against those affected, unfortunately. You are the bridge between scientific evidence and the public's understanding. Our commitment to responsible reporting, we can dispel myths, educate communities, and foster trust in our public health systems. I urge you to focus on the following. One, verify information. Partner with the health authorities and technical experts to provide factual, up-to-date information. Two, promote preventive measures, as the PS just said this morning. Highlights the importance of hygiene practices, vaccination, and community solidarity in mitigating the spread of Mpox. Three, avoid stigmatizing language. Sensitivity to avoid alienating or stigmatizing affected individuals, and collaborate with us. We are here to provide you with the information you need. Open communication would strengthen our collaborative ability to address this, strengthening our working relationship, enhancing our knowledge of Mpox, and reinforcing our Kenyans with the knowledge and their families. Looking ahead, it is essential that we strengthen our collaboration in addressing public health challenges to. I would like to propose that in the future, we consider hosting by the Ministry of Health leadership with the lead agencies such as WHO, UNICEF, IOM, Africa CDC, US CDC, and other collaborative media briefs will not only also amplify our shared efforts to promote accurate and timely information, which is vital in combating health emergencies.
With our team.
And finally, Caroline. Caroline, where are you? Thank you so much, Caroline. Trackers Union. So Elijah, let's appreciate Elijah as he comes in. Karibu sana.
Good morning, ladies and gentlemen. Mko salama? Asante sana. Kwa majina naitwa Elijah Nyaga. I'm the chairman for Long Distance Drivers and Conductors Association. Indeed, let me say the issue of Mpox is really affecting us, and especially the long distance drivers and conductors. I think we are the key and vulnerable population. And we play a very big role in transmitting the virus. And also, I believe we also play a very big role in stopping the spread of the virus. But I think for a very long time we've not been in partnership with the Ministry of MOH, and especially on Mpox. But I think this time round, ensure that we will say thank you for feel that there is education and awareness. The Ministry of Health can collaborate with the Drivers Association to distribute on the move and may not always have access to regular health checkups. So providing them with the tools to stay informed is essential. Number two, health major stops where drivers stop. These clinics could offer on-site vaccinations in case there is, screens and health consultations, making it easier for drivers to stay healthy and seek timely care when needed. Number three, preventive measures. Drivers can also be proactive by following basic hygiene practices, such as wearing masks when necessary, avoiding close contact with those showing symptoms of illness, and maintaining proper sanitation practices inside the vehicles or trucks. The Ministry of Health can provide training on these best practices, ensuring that drivers are equipped with the knowledge to protect themselves and those they interact with. Number four, tracking and reporting. With the assistance of drivers, we can set reliable system of track any potential cases of Mpox, ensuring that proper measures are taken if an outbreak occurs. By having drivers report symptoms early and share their travel routes with health authorities, we can effectively prevent further spread of the virus. Number five, community support and responsibility. In the end, this is not just about protecting the health of drivers, it's about safeguarding the well-being of the wider community. Through the shared responsibility and commitment to public health, drivers and the Ministry of Health can help create a safer environment for everyone. By joining hands with the Ministry of Health, we can help ensure that we tackle this disease effectively and prevent its spread. My urge is we work together to protect ourselves, our communities, and the essential services that keep our economy moving. Remember, drivers, we play a very big role because we move the economy. By number one, we transport cargo, and number two, we also transport passengers through the borders. So we play a very big role, and I think working together will help minimize the spread of the virus, and our involvement in the campaign and sensitization is also key. I would also like to urge the media, because the media also they are key partners in sensitization the campaigns. We encourage them to focus on the importance of early detection, prevention, and the role drivers can play in stopping the spread of the disease. Drivers are not only essential workers, but can also act by spreading awareness within their communities, following hygiene protocols, and seeking care at the earliest signs of symptoms. I think that is the message we have today for you, and tunashukuru sana for the ministry. We are looking forward to working together with you. Please open the door for us, because the doors have been locked for a very long time. So, asanteni sana. God bless you.
Let me shake your hand. Thank you so much, Elijah. First time we are having them. Let's appreciate it.
Good morning, everybody. Drivers Union. Only long distance truck drivers. Drivers will not report come somewhere with I want for have spread these Mpox materials along the northern transport corridor, which runs from Mombasa all long engaging the
Members of the fourth estate, you've heard us, you've seen the stakeholders, and you are a key stakeholder as members of the fourth estate. We're in this journey to be with you, and now we want to present our local situation. We'd like to give you some data so that whatever we release through you is the accurate data. So you'll allow me now to invite Dr. Michelle just to be able to share the local data, the national outlook. After, we'll have Dr. Livinas from WHO to be able to give us the global picture of what we are dealing with. Dr. Michelle. Continue enjoying your breakfast, please. So, Dr. Michelle.
Good morning, everybody. Our Ministry of Health leadership, our very highly esteemed partners, our response stakeholders, and my colleagues in the Mpox response, a very good morning to you, and it's such an honor to stand before you and give the update on the Kenyan situation. Before we get into the Kenya situation update, let's first go through the outline of the presentation. Okay, so first we are going to go through a basic introduction to Mpox. After that, we are going to look at the situation in Kenya and some highlights of the response which has been going on since the outbreak was confirmed in July last year. And then we'll have acknowledgments. So Mpox is a viral disease. It's caused by the monkeypox virus. And this virus belongs to the same family as the variola virus, which causes smallpox. It's a zoonosis. A zoonosis is a disease which affects both animals and humans. So the animals which are affected are usually the small mammals, like the monkeys and the squirrels, and it also affects humans. So the transmission can be from animals to humans, and it can also be from human to human. So this is just a graphic showing some of the mammals which are affected. On the left of the graphic, we can see the animals there. So people come into contact with them when they are handling them. The people who go to hunt for bushmeat, and also during the preparation of the bushmeat. And the contact can also be bites or scratches from the animals. Then on the other side, which is more relevant to us in Kenya, is the human-to-human transmission. And this occurs through direct close contact with somebody who has Mpox. It can also occur through respiratory droplets when you talk face-to-face with a person who is infected for a long time. It can occur through needle injuries, as may happen when people are getting piercings or in health facility settings. It can be vertical from a pregnant woman to an unborn child. And it can also be sexually transmitted. This is very relevant to us in Kenya. This is one of the main ways that it's getting transmitted in Kenya. So next slide. I'm very proud of this slide. These are the symptoms of Mpox, and this analysis was done for our first 23 cases in Kenya. So these are actually the symptoms that were reported by patient 1 to 23 with Mpox in Kenya. So we can see that most of our patients reported that they had rash. Actually 100% came with a rash. Then fever, sore throat, genital lesions, body weakness, just feeling generally tired, joint pains, and oral lesions or lesions in the mouth, and so on. So this is actually our Kenyan data of what our patients with Mpox complained of. So why should we be concerned? So many people have been wondering and asking, should we really be concerned about Mpox? Why are we making such a big deal out of it when we just have 36 cases? Is it a big deal? Should we be bothered, or should we just stop and forget about it? The answer to that is that we should all be very, very concerned about Mpox because one, while most of the patients recover from the disease, there are some populations who are very vulnerable. These are the young children, pregnant people, and people who are immunocompromised. Immunocompromised people are, for example, people who have HIV, which is not well controlled. So these vulnerable populations may get severe disease, and Mpox actually can cause death. And many people have died because of Mpox and its complications. So we should be very concerned about it. We have even one person who died in Kenya from one of those vulnerable populations. Then apart from that, it can also cause complications. You can see like the patient who is illustrated there, her skin is extensively involved by the disease. You can see the lesions are all over. These lesions can get infected. Sometimes they happen in the mouth, so the person has difficulties with feeding and drinking. The lesions can get infected and the infection can spread through the blood, what we call sepsis. And sometimes even the eyes can get infected and people can get loss of vision. So while most cases of Mpox are fairly mild and the people recover, it can be quite serious and we should be very concerned about it. Then in addition to that, there are also the psychological and the social and the economic complications. You can see a patient like this with lesions, she can't even go in public. She'll be very stigmatized. She cannot attend her work, or if she's a student, she cannot go to school. And if the patients become very many, then the health system can get overwhelmed. So we should be concerned. Next slide. So there are different types of Mpox virus. We have what is called clade 1 and clade 2. In Kenya, it is clade 1b, which is circulating, and it appears to cause a more severe disease than the clade 2. In addition to that, it's associated with a higher rate of human-to-human transmission, like what we are seeing in Kenya. It spreads easily between people. It affects all sexes and all age groups. If we remember in 2022, we had an outbreak, a global outbreak, which was primarily involving the men who have sex with men, and that one was caused by clade 2. That outbreak remained primarily in one population. Ours is affecting all ages and all sexes, and there's a lot of heterosexual transmission. That means between men and women. So we should be very concerned in our setting. Next slide. The map. No, go back. Yes, that one. So here I just want to highlight to you about Mpox clade 1b. Everywhere where you can see blue, in the Central Africa, in the Democratic Republic of Congo, that is where the outbreak, that is where clade 1b was first detected, and it was actually detected for the first time in 2023. Since that time, it has caused a massive outbreak in the Democratic Republic of Congo, and it has spread to other countries in the region, including Kenya. This is clade 1b, Rwanda, Burundi, and Uganda. These countries like Kenya, Rwanda, and Burundi have never had Mpox in the past. This is the first time we are encountering Mpox, and it's because of this clade 1b. So we can see that it has a high outbreak potential, and it has left where it started in the DRC and spread to other countries. If you look at the other continents, like the North America and Europe and Asia, that is India, I'm sure you can see where India is, you can see that the 1b has also spread to other continents. It is yet to cause an outbreak outside of Africa. These are mostly imported cases where somebody travels from Africa, travels to Africa, gets infected, and goes to either Europe or America or Asia. But you can see 1b, it has really spread, and it has spread in a short time, 2023 to 2025. So that's another reason why we should be very concerned. Next. So let's come closer home. This has been very well outlined by the speakers who came before me, especially our principal secretary, but let us just go through it for emphasis. So in Kenya, we declared our outbreak on 31st of July 2024. Our patient number 1 was a truck driver, and he was detected at the border between Kenya and Tanzania at our border crossing at Holili, Taita Taveta County. So subsequently, and until now, we have 36 confirmed cases, and the cases are spread in 12 counties. So the map that we have there is just showing us the counties where we have cases of Mpox, and you can see a very clear pattern where the cases are distributed along the transport corridor that goes from Western Kenya until the coast. We can also see involvement of counties along the border with Tanzania. That comes out very clearly in the map. So our outbreak is still very active. Our most recent cases were reported on 20th of this month. So just within this week, we reported 3 more cases in Kilifi and Busia counties. So very much an active outbreak. 32 of the patients have recovered. This is a very good thing, but 2 are still admitted in hospital. 1 is on home-based care, and unfortunately we lost 1 patient in Bungoma County who was one of the vulnerable populations who we have mentioned. In Kenya, females are more affected than males. We have involvement of about 61% females. So this again is work done by our team for our initial cases of Mpox, and all I want to show you there is that it's distributed across all age groups. So from age 0 until age 60, we have cases, but the most affected age group is from around 30 years to around 44 years. So that is clearly illustrated in the chart, which is showing right now. Next slide. Okay, so something else very relevant to us is the occupations which are involved. We can see truck drivers are the highest number, although this was a bit earlier in the outbreak, but we can see that at that time the truck drivers were the most involved population, followed by business people and female sex workers. It's also important to note that we have children, we have some students, these are secondary school students, and other professions. So these are the occupations, just to give us an idea. And it's a very good thing that we have our truck drivers represented in this meeting. We really need you in our response. Next slide. So what have we been doing? We've been having a very active response. It is led by the Ministry of Health, and we are very well supported by our partners in the response and our stakeholders. So a very big thank you to all our partners and all our stakeholders for your support. Thank you so much. So in terms of coordination, we have a coordination structure in place. I'll show you how it looks. We hold regular coordination meetings, and we have an Mpox emergency response plan, which is illustrated there. Next slide. Okay, so what this is showing is our response structure. This is what is called an incident management system, and it is led by a task force chaired by our principal secretary, who was here with us. That is our highest decision-making body. They offer us strategic leadership, and they also assist us with resource mobilization. So below that, at the operational level, we have what is called an incident management system, and this is led by our incident manager, who is our Deputy Director General for Health, who is here with us. He's here. Then we have 4 sections. Operations, that's the main section. These are the people who deliver the interventions. We have risk communication and community engagement. This is the group that has brought us here today. We have our health worker capacity building. We have infection prevention and control, case management. the ones who guide us on taking care of the patients. We have mental health and vaccination. Then these other sections, plans, logistics, and finance administration, our job is to support the operations team so that they are able to deliver the interventions very well. Next. So we've talked about the risk communication and community engagement. They've done a fantastic job. We can see the materials they've created all around the room, and even the one projected there has been created by this team. And they've been doing great dissemination, press releases. Each time we have a new case, this team ensures that a press release is given so that the public can know about the cases. They also do a lot of social media. They did some TV and radio dissemination last year. They do direct community engagement, advocacy meetings like the one we are in now, and of course, as we've said, information and communication materials. Next. Very important, enhanced surveillance at our points of entry. Our teams at Port Health have been able to screen over travelers for Mpox, just to make sure that we don't get cases coming into the country from outside. They also do contact tracing. This means that whenever we have a case of Mpox, they go and find out who are the people who came into close contact with that person, and they follow up those contacts just to make sure that they are okay and they don't develop Mpox. So we've been able to list 244 contacts, 216 completed the 21-day period of follow-up uneventfully, 19 are continuing, and 9 developed Mpox while they were on follow-up. So we also have what are called rapid response teams. These exist at the national and the county level, and their job is to be deployed to an area which is identified as a hotspot for Mpox. The most recent teams that we deployed from the national level, they went to Nakuru, which towards the end of last year was having very many cases. So there's a team that went there. They actually went in December over Christmas, and they just supported the county teams in controlling the outbreak there. And another team went to Mombasa. Okay, the laboratory, this team, we can't thank them enough. They have a sample management system in place. Our testing is happening at the National Public Health Lab. So there's a very good referral system so that the samples can come and be tested. And there's also a quality assurance system where they share the samples with other labs just to make sure that there's concurrence in the results. So they've tested 386 samples which have come to us from 38 counties. 36 have been positive, 348 were negative, and 2 are pending. They are still in the process of testing. We are also doing health worker capacity building. We've done quite a number of trainings. The image there is a training that we held with the county health teams from the coastal region, just to educate them on Mpox. And now these county teams are educating at the sub-county and the health facility level. We also have guidelines for Mpox. So as I come near the end, the Ministry of Health and all our response stakeholders are very committed to controlling the outbreak. We are very committed, but we all have a role. The media, the public, everybody who resides in Kenya, we have a role. And what can we do? We need to observe strict hand hygiene. This is hand washing and use of hand sanitizers. We need to avoid sharing personal items such as clothing and beddings and towels. Each person should use their own. If we detect symptoms in ourselves or in somebody close to us, we need to report to the nearest health facility so that we can be evaluated. Not every rash that appears is Mpox. So one needs to go to a health facility so that you're tested, you get a diagnosis, and receive the right care. Then very important, we need people to be responsible in their sexual conduct, either abstain or be faithful to a partner who is also faithful to you. Avoid multiple sex partners. This is a risk factor for Mpox. So acknowledgements, I need to acknowledge the Ministry of Health, both at the leadership level and my colleagues. Thank you so much for everything that you have done for this response. I also acknowledge UNICEF, who are our main supporters for this event. They've been with the risk communication and community engagement team from the very beginning, doing a fantastic job. They also support us in the case management, and they also support us in water, sanitation, and hygiene. So thank you very much, UNICEF, highly appreciated. And then our leaders in health, the World Health Organization, we cannot thank you enough. You do so much, not just for the Mpox response, but generally for the health system in Kenya. So a very big thank you to the World Health Organization team. And all our partners, our stakeholders, the representatives of truck drivers, religious leaders, all Kenyans, the media, we rely on you so much to pass the right information to the public. We are truly, truly grateful. So with that, I come to the end of my presentation, and thank you very much.
Thank you so much, Dr. Michelle. Members of the fourth estate, when we shared the invite, we received 25 questions prior. And those 25 questions, some of them have been answered and we'll continue answering them when it comes to that time. We value you. Fourth estate, please wave to me where you are. Aha. So, thank you so much. I'm waiting for Dr. Levinas, the global picture. Right, I know he's with, yes. So we will give him a chance. But now please allow me to invite our own colleague, Leila. Please, Leila from UNICEF. Leila, please, as she comes in, let's appreciate Leila. Remember, the call from us under the leadership of DDG, Dr. Sultani, is that all of us were in this game. And we appreciate everyone. Leila, are you ready? Please come, I'm waiting for you, Leila. Yeah, yes. Yes, Leila. Shake my hand and say, Karibu sana, Leila.
Thank you. Thank you very much. My name is Leila Abrar. I am from UNICEF Kenya Country Office. With me is my colleague Nancy from WHO. She's my partner and my counterpart at WHO. We're going to walk you through, we don't have it there. As we get the laptop, we're going to start talking with you about working with the media to manage health misinformation and disinformation, otherwise not known as infodemics. A lot of our previous speakers have talked about the role of the media and how important that is. We really want to dig a little bit deeper into how the public's confusion about the accuracy of information or misinformation actually undermines trust in health authorities. It undermines trust in health services. It fuels public skepticism, and it complicates effective disease control and prevention. So it's really, really important to be able to manage infodemics, as Nancy walks up here. The role of the media in managing misinformation and disinformation cannot be understated, because our goal overall is to make sure that our communities are well informed. And so we'll go, as we move to the next slide. We just want to explain and define what infodemic is. Most of the time people think infodemic is the inaccurate information. As a matter of fact, as defined by WHO, infodemic simply means the overabundance of information. So some may be accurate, some may be fake news, but really just the overabundance, the public being bombarded with a lot of information, especially when there are epidemics or outbreaks. This can lead to confusion and untimely mistrust in governments and the public health response. So no matter what the government of Kenya does to respond effectively and efficiently to Mpox or any possible Marburg, as long as there's infodemics and confusion in the public eye, it will always undermine. And why is there infodemics? For three reasons. One is when there's an information gap. So people, of course, anytime you hear there's an outbreak, we're always seeking information. But if we find a lack of credible sources, including our media, then this can lead to rumors and misconceptions. There's also misinformation, which means inaccurate information which circulates through the networks. And Kenya has a very active social media. You can see that there are sometimes a lot of inaccurate information that are circulating within a network and that needs to be corrected. Then, of course, there's disinformation. This, in fact, are intentionally designed and shared through public spaces, social media in particular, to achieve an agenda. This is what is sometimes known as fake news. So the impact, as we said earlier, of infodemics were not managed. What you see in front of you on this slide are some of the major themes that our organizations and the Ministry of Health are picking out through social listening and media monitoring. So on a weekly basis, we are on a daily basis actually, but giving out a report on a weekly basis, we're monitoring what is being said, both online and offline, so that our programs can respond effectively. So one of the first major themes is the skepticism on disease spread. There's a narrative out there that Mpox was created so that the remaining COVID-19 vaccines can be used up. That is fake. Distrust in government. This narrative says that the Mpox only happens when there are public protests. This is incorrect and not factual. Mpox happened because there's an outbreak in the region, and Kenya had to respond to protect Kenyans and people living in Kenya. This other major theme is conspiracy theories about vaccines. This one accuses global figures of using the vaccines as a tool for other motives. This is also not based on fact. This is in fact fake. Distrust towards global agencies, that Kenya is being used as a testing ground for vaccine experimentations and so on and so on. This is not accurate, this is fake. Distrust in public health initiatives, which is a narrative that links Mpox to broader concerns such as cosmetic chemicals and all of that. The problem here is if these are not addressed, they will really lead to public skepticism. And then the last general theme that we have been picking up since the onset of the Mpox outbreak is general frustration. There is repeated mentions of systemic failures and a failure to manage health in an effective manner. This kind of narrative in the public space leads to mistrust and a feeling of neglect among some citizens, which disempowers people from seeking health. And as you can see in this next slide, unless these narratives are addressed, there's a high risk to health. So the highest risk will always be the health of the priority groups that we have to reach in order to interrupt the transmission of the outbreak and to protect the public. So the false narratives out there lead to vaccine hesitancy and reduced uptake among the high-risk populations. This is a big problem in Mpox because we know that the earlier one seeks treatment, the highest rate of recovery. So it's very important for people to get the right information, seek care so they can recover from Mpox. False information suggesting that treatment is more dangerous than the disease itself also discourages people from seeking medical care early, so that the recovery rates may be much higher. Narratives suggesting that Mpox affects only certain ethnicities, and we see this more in our neighboring countries, create a false sense of security among the other groups, saying, hey, this does not affect me. It probably only affects truck drivers, for example, in not ethnicity but occupation. Mpox is a risk to all of us. Misinformation about Mpox can also have severe consequences, as was said by the Chief of Health from UNICEF earlier in his remarks, severe consequences for children's protection and well-being. Common misinformation, such as Mpox is a conspiracy, for example, may lead to reluctance among parents and caregivers to seek timely medical attention or take preventative measures to protect children. And we see in our neighboring countries, for example, in the DRC, where children are very much affected by Mpox and have some of the highest mortality rates from Mpox. Addressing these false narratives is essential to managing the public's response to health emergencies, and that's where the media is critical, and that is where you can play the best role in making sure that the public's response to Mpox or any other health emergency is well managed by providing the correct information. And at this point, I will call my colleague Nancy from WHO to take you through some slides on the importance of media and what the media can do to manage health emergencies. Thank you very much.
Thank you, Leila, and thank you all the other colleagues that have presented this issue earlier on. I must say that if you can see, there's a consistency in the message that they're all passing. So firstly, we are all saying the media is a very key player, very, very important in setting the agenda of what is being said or discussed within the Kenyan space, and even has the capacity to change attitudes and behaviors. And so we really appreciate your collaboration. I think we can stop for a moment and just clap for our media, our colleagues in the room. Thank you very much. So to continue again with what I'm saying, so firstly, the media is important because you come to bridge the knowledge between public health information and what the communities are talking about. You're the ones who are helping us. We can sit here as scientists, as people with data, but you're the ones with the community, you're the ones with the public. And so you bridge that gap, and so you have a very, very clear role in terms of what you're supporting with leading the health agenda in Kenya. Number two, you also help us to identify and flag misinformation. Seated in offices, we really appreciate whenever we get a call from the media asking, is this the correct information, you know? And so we really appreciate that you're able to identify and flag this misinformation. Some of them we don't know. But given the power that you have to speak with the public in a regular basis, you are able to bring to us this misinformation, and thereby you play a very important role of identifying and flagging misinformation that threaten public health response efforts. And thirdly, disseminating evidence-based credible information. Like I said, you hold the power to be able to pass information. And so the ability for you to disseminate evidence-based information is a very critical role. It's easy for Kenyans to be influenced by fake information, misinformation, but because you have the evidence, by virtue that you can access UNICEF, IOM, you can access WHO, the Ministry of Health, you have evidence-based information that you can share with various publics. I think you also hold a very important role in terms of you serve as a stakeholder in national response. Without the support of the media, we cannot manage health emergencies. Again, you hold that space. You are trusted. And so we hold you as a key stakeholder when it comes to managing national responses, as well as preparedness plans. Earlier on, our peers talked about this Marburg already announced in Tanzania. You, as the media, you are one of the avenues and the channels that has been able to spread this information the moment it was announced in Tanzania. Most Kenyans would not have known about it. And so you are such a critical stakeholder in preparedness and response. And lastly, you help to facilitate interaction between health experts and the public. We see in most of your talk shows, you invite experts, then you ask them the questions. So you give us that platform. And so where we are seated as organizations represented here, we really value you as the media in Kenya. Now, we've interacted with you, and we've also noticed that there's some practices that we can say, these are good practices that we want to say, let us continue, so that even health response is managed properly in Kenya. And I'm going to call this the do's. So in short, the role of a journalist and the do's from some of the best practices that we've picked over the years. So number one, we're suggesting that you get your facts right. You know, there's a temptation sometimes to run with the news and be the first to report it, but we are just opening up this discussion, and we are asking you, get your facts right before it is shared. Secondly, stick to the facts. It is easy to add some sensational, juicy side of a story, but if we do that, then we are not helping management of health emergencies in the country. And so we appeal to you to stick to the facts and the messages that are provided by credible organizations such as the Ministry of Health, WHO, UNICEF, and other organizations represented here. And then we say we need to keep it simple. COVID is one of those that the misinformation around it was so much because nobody was understanding it. But we are appealing to you as part of the responders to health emergencies to see how you can communicate simple messages, so simple that even our own grandmothers can understand, because they're still stakeholders and they're consumers of the information that you pass in the media. The other one is about technical terms. We appealed for you and to you to ensure that you're using the simplest terms possible so that our publics can also understand big jargons like Mpox. I'll give an example. We no longer call it monkeypox, we call it Mpox. So members of our media, we appeal to you again, let us use the correct terminology so that the public is also able to understand what is happening in the country. We also suggest that you can get credible people to back your stories. Earlier presenters and speakers here have said that they're available for interviews, you know, so that you're being given factual information. And the last one, schedule interviews. During emergencies, we tend to find that we are always in the field. I think most of us in UNICEF, IOM, WHO, Ministry of Health, we are always in the field when there's an emergency. And so we just seek that you give us an opportunity to have an interview. You call us, you schedule it in advance so that we are not missing that opportunity to interact and only one side of a story is being covered. In the same cipher, we've also picked some practices that we are saying are not very good practices, and we are hoping that going forward, these practices can also stop. So for example, picking up unverified information from social media and making it news. And I'm sure your journalistic ethics also guide you on this. The second one is sensational headlines. Recently, we had one of the media houses, I'll not mention them because I see them in the room, putting a very catchy title. And when you go to the content has nothing to do with that title. It's very misleading, okay? And we know that Kenyans sometimes don't have the time to go into the entire article. So it's just a title that is enough to make misinformation spread. And so we appeal to you to ensure that you're using headlines and you're using content and part of the stories that are actually factual. Like I said earlier on, let us avoid using technical terms and jargons because we are speaking to a variety of Kenyans outside there. Another one is avoid covering any gatherings or press conferences that risk your own health. It is so easy to run for the news, but we still need you alive to report for news tomorrow. So see how to balance that in a way that you are still able to report on news and still protect yourself. And lastly, avoid details of patients to the public because as WHO earlier on talked about stigma, it's a real issue. And our truck drivers who are in the room will tell you when Mpox became an issue in Kenya, people started avoiding trucks. You see a truck, you don't want to go closer to a truck driver. And so we also need to manage how stigma is being spread whenever we have health emergencies. That said, I'm going to lead you to this slide that is going to lead you to where we believe you can get correct information. Of course, firstly, we are directing you to the Ministry of Health, a very, very credible source of information. We're also highlighting the UNICEF Eastern and Southern Africa website, and you can see there's various topics about Mpox there. Very updated information that you can pick all the time. There's also Internet of Good Things page on Mpox. You can get more updated information there. And lastly, there's a social media kit for Mpox, viral facts videos. If you came earlier on, you saw some of the videos you're playing here. We've tried to also create some short videos that we can also share with some members of the media. And they're very short, but essentially they try to debunk any misinformation that we've picked in our usual social listening. That said, thank you very much, and I wish you good deliberations henceforth. Thank you.
So to the two ladies, Leila and Nancy, can we have a double way of appreciating them? One more time, please. So to the media again, where I sit and where we sit, we value. And that's why we are here today. So we're almost there, but we still have few speakers. So Dr. Martins from WHO will be here to give the global picture, because we are part of the team. We are in Afro. We are part of this team in the world. And then after Dr. Martins, we'll invite Rosalia Kalani to tell us about issues of vaccines. And please come in, Dr. Martins. And I still have these questions that you shared with us earlier on. There are 25. So please, as we continue talking, pick those answers. And where you'll be not so sure, we'll still come back. Dr. Livinas.
Thank you, Chief Limbo. Good morning. Good morning, everyone. Good morning. My name is Martins, and I work with WHO. I'm here to, that's my presentation, and to show us the update of Mpox globally, so that we'll see what is happening, so that we know that Mpox is not just in Kenya, but it's a global outbreak. And in fact, WHO has declared it public health emergency of international concern, according to the IHR. So that's why it's now a global effort in responding and preparing in the cases where the countries it has not been affected. Countries have not been affected yet, but it's a global response and global effort. Next slide, please. So this slide is giving us the outbreak situation from 2022 to 2024, and in most of the regions, and also showing the rapidly increasing cases in the African region. Now, in WHO, the African region is made up of 47 countries. So when we say the African region in WHO, we are talking about 47 countries out of the 54 African nations. And since 1st January 2022, Mpox have been reported to WHO from 127 member states across the 6 WHO regions. That is across the world, the whole countries in the world. 127 countries have reported it. And as of 30th November 2024, a total of over 117,000 cases has been confirmed by laboratory. And this includes 2 probable cases. And also we have there's a report of 263 deaths that have been reported to WHO. And the 10 most affected countries globally since 1st January 2022 is Brazil. You can see the number there, the DRC. You can also see the number there. And there is Spain, there is France, Colombia, Mexico, the UK, and of course Germany and Peru. So the numbers are all there. So if you look at these countries account for above 77% of the global burden of the cases. So if you go to the next slide, it's trying to show us the trend that we have. Now, if you look at the trend, you can see that most of the African region is still having the big share of it. If you look at the cases, you look at the trend that we have there, if you look at the color, you can see that the African region will still have big, and this also includes the global deaths. So, is the expansion of the Mpox in the African region is unprecedented. If we can look at it from the curve. So we're trying to now. I'm trying to now take it down to the African context of the update. You can see that since 2022, we've had over 21,000 cases that that have been confirmed by laboratory, and we've had 86 deaths, and the number of countries that are reporting are 22. We also have the laboratory that have been confirmed since 2024 is over 18,000. You can see the exponential increase within the last 4 years. Is it 4 years? Yeah, last 2 years, last 3 years. So, and 64 cases have been confirmed by laboratory. Now, the number of countries reporting is 19. So you can see the increase. If you look at it from 2022 to 2024, and from 2024 till now, you can see that there have been a lot of increase in that. And the cases that have been confirmed in this year so far is 526. 2025 started with a bang, right? So, but no death so far this year. And the countries that are reporting this year so far have now come down to 6. So you can see that again, 22 countries have been affected since 2022, and 15 countries are assessed as active. So those countries that are assessed as active, Kenya is included. You can see it there. You can see my slide, right? So that with the discussion, we'll be looking at it together. It's good to have the media here. So currently, the countries that have been newly affected is Sierra Leone, is the new kid on the block. So they have joined the group of us that have been there, and about 5 countries are in control phase. Also, there are also 4 countries that are, they are nearing the end of the outbreak because they've not reported for more than 90 days of cases. So we hope that very soon Kenya will also be part of this number. So look at the situation that we have in the African region. I just put it there for us to look at the countries. Of course, in Africa, the African region of WHO, DRC is leading, one of the highest there. You can see them. So you can also see the report on the box by your left. You see we put the cases by a week, but we didn't include DRC in those cases in the box in the left. So you can look at it by the time we share the slides to you. So this is the trend. If we look at the trend by map, you can see that the trend, if you look at January to April 2024, you can see the map. It was just concentrated in the central area and western area of the continent. Now, if you now look by the time we now got to August, it has now spread from the central area towards the Eastern African and the Southern Africa, right? With a little bit of gap between the two. There was no breach. Looking at it, if you look at the second map, there was no breach. There was a gap between the Central and Eastern and the Southern. But that gap was now breached as we approached December. So you can see the thing is spreading very fast as it is. The fear of this spreading like this is you cannot begin to also think of other more infectious diseases if it were it. We are having cases where they just declared the Marburg outbreak in Tanzania, I think on Tuesday. So disease in one part of the world does not mean that you are free if it's not yet there. It moves like spirit. So this is the clades, this is the types of the Mpox that we have in the African region. I will just put this slide so that the media will also follow us to it. There is the clade 1A, which is predominant in Central African Republic, the Congo, DRC, and in Cameroon. Then you have the clade 1B, which of course is in Uganda, Kenya, Rwanda, Uganda, Zambia, and Zimbabwe. Then there's the clade 2, which we have seen in Cote d'Ivoire. There's the clade 2A. Clade 2B is in Nigeria, Ghana, South Africa, and the clade 2, just class 2 is that's A plus B. The both one is found in Liberia. So these are all the stuff. You see, this class, some of the features is that it has higher severity and mortality in immunocompromised individuals. So maybe we'll have more questions. People want to ask questions, we can answer it later. So this is my last slide. The drivers of Mpox, if we look at it, is the urban density. Of course, when people live closely together, the disease can spread easily. The cross-border spread. We didn't have it before, it now crossed over because disease knows no border. That's the close contact, that's the primary transmission route through physical contact and the rest of them that we know. Then what are the challenges? There are large backlogs. Despite high investigation, from our study, we see that over 40% of suspected cases remain untested because of gaps, whatever we can say. The resource constraint is also one of the challenges, which means there are limited capacity for isolation and treatment in rural settings. There is the community adherence, difficulty and gaps in people understanding the public health implication, what it is all about. You know, how do we adhere? How do we keep ourselves safe? That's why we are having this interaction, because we bank on the media to help us propagate that. I think the PS and the other speakers, including WR, alluded to that preventive measures. The stigma is also a problem. You know, there's cases in the community remain underreported because of fear of stigma, and that's why we're intensifying the awareness campaign. Also, staffing. You know, staffing to be able to help to prepare and respond is not enough. It can never be enough. You know, in terms of the response. So staffing. Most of the colleagues are multitasking, doing 2, 3, 4 more things to be able to respond. So the health workers on the ground, Mpox is not just their primary role, right? They have other things they also have to adhere to, so that's also a challenge. And also the inadequate sequencing reagents of some of the labs. Kenya were able to sequence, but not every country is able to sequence. That's also a challenge on that. So that is just to give us a global perspective of the Mpox outbreak, and I hope the presentation will make sense to us. Yeah, it did. Thank you.
Please, are we tired? Kindly request that we really appreciate Dr. Livinas. One more time. So before I invite Kalani, I request we stand for a minute and stretch. We've been sitting, please, all of us, kindly let's stand. You know, I work for this sector, so kindly, all of us, Mercy, please stretch a bit, kidogo. Yes, stretch a bit, kidogo, for 1 minute, just. It's good for us, it's good for our health. Yes. Let's take our seats, please, ladies and gentlemen. And it's my pleasure to invite Ms. Rosalia Kalani. And remember, one of the key messages that came from our PS was about the issue of vaccine. So, Ms. Kalani.
So good morning, still a morning, to our very key stakeholders, the media. Thank you, Limo, to my colleagues and our partners. Allow me to give an overview of the Mpox vaccination strategy. So when Dr. Michelle was presenting, she said that we have an Mpox outbreak response plan. So in that plan, we have a strategy for vaccination. So Mpox is one of vaccine preventable diseases, okay? So as a country, we've developed a deployment plan for the Mpox, which has been extensively informed by what Dr. Michelle presented in the morning, our epidemiological data. Okay? So I think you'll allow me to make the move. I have maybe issues with my sight so that I can see clearly the slides. Okay? I needed the laptop, kindly. So when you look at that slide, this is not the first time we are having the vaccine for Fox, the Fox vaccine. In 1950s, 1970, we had the smallpox, and there was a vaccine. And there was a vaccine for that. Sorry for this. IT guys, kindly. Sorry for this. The media don't capture this. Kindly. Cohort. You remember we had also had the smallpox vaccination eradication strategy, which was happening. Okay? And most of us can show it. We were vaccinated. So this vaccine prevents smallpox and the Mpox diseases, and especially in high-risk individuals. I think later, and from the previous presentations, we've been able to see clearly who is at risk of this disease. The new Mpox vaccine, they are calling it third generation. Right from during the smallpox, the virus keeps, of course, changing. So it has been changing, and now we are in the third generation. It's not a different vaccine, but I don't want to go into scientific details of antigenic drifts and shifts. But the virus keeps on changing, and it is that change which informs what will be the current formation of the vaccine. So as of today, and as what we have as the Mpox vaccine, they are calling it the third generation vaccine. And this third generation, they are saying, does not produce a lesion. Okay? You can see mine, I can still show it, and maybe for ladies it might not be very comfortable to show because somebody can easily calculate your age. So to us that is also a plus. It is not going to produce this new one, and it has really been improved in terms of safety compared to the other two previous generations. So of course we are always guided by the World Health Organization when these outbreaks occur, and they give recommendations which we also tailor to our context, okay, relating to especially the data and what is happening in our populations. So this vaccination is recommended for persons at high risk of exposure to the Mpox outbreak, okay? So based on what us as a country, and I think this was shown, we've been collecting data. This is what they are calling epidemiology. We've been collecting data which tells us who is getting sick, who is this person, the age, okay, the activities around this person, the occupation, so, and where are these people coming from? When Dr. Michelle was presenting, you could see the corridor. So this data gives us the geographical definition of where we are getting the cases and who are these people who are getting the cases. The other high-risk groups, so we'll base our vaccination on that data. We are also guided to base our vaccination on the risk groups, okay? Sex workers, the gay, the bisexual, other men who have sex with men and have multiple sexual partners, individuals also who have multiple casual sexual partners are also included in this high-risk group. Again, because when these people get sick, they also have to be attended to. They have to be case managed. We also have our team, which are the healthcare workers, okay, working in the laboratories. You've heard the good work the lab is doing. The healthcare workers who do the detection, the healthcare workers who are in the surveillance, the healthcare workers who are participating in the response system are also at risk, okay? And then there is also this other group, these individuals, the cases, these persons who get sick, they are not confined or excluded in a place. They still have their activities. They still have people around them. And these are the people we are calling the contacts, okay? So right from the household to their workplace, to their transportation aspects, we have contacts. So when we look at the activities for a certain period, you can be able now to collect the contacts of these cases. So this vaccination, of course, will be a phased vaccination. We'll look at phased strategies. So immediately, because we are in an outbreak, the first phase is we are responding, okay? Vaccination is one of the key strategies, very significant in outbreak response. And we were told we are in an outbreak situation as a country, okay? So we'll have to stop the outbreak. And one way of stopping the outbreak is targeting the contacts of the cases, okay? And more so, the frontline workers and healthcare workers. This is not the first time it is being used. We are not the only country who are using this vaccination strategy as a response strategy. Other countries like DRC, Rwanda, and Nigeria, they have been able to get their vaccines and they have been able to deploy them. After this, we can get to phase 2, and we'll have an expanded protection where we also look at people who are high risk of getting the severe form of the disease, okay? And this will be informed extensively by our local data, the information which we get from our system, and Dr. Michelle showed you the pillars and the kind of strategies out there. The investigation team, our surveillance team, our epidemiologists, all that information which they are bringing on board will really inform who now gets the expanded protection. And then we have that phase which WHO has guided that in future, with recommendations from the vaccine groups, we can now get to other groups. So I think we've talked so much about who is at risk of Mpox infection. So these are individuals who, during the infectious period, have had direct physical contact with case or their body fluids, okay? The infectious period here is being said to be the time when we see the rash. That is when the rash is present, and this can last to 2 to 4 weeks, okay? This can also be those who are in close proximity to people who are already showing signs and symptoms, okay? And we are targeting approximately per case 20 persons. So when you look at that picture, the red case, look around that case. Maybe they're not 10, they're around 19, but look at the activities around that case. You can see there's the aspect of close contact, including but not limited to sexual contacts. I think that is very, very important to us, okay? Then there's also, this person will travel. This person, of course, is not idle. this person will be housed maybe somewhere. Of course, we have households where we only have one member, but ideally we have households which have other members around, okay? So the conduct of at household level, the family members, other people in the same institutions, like us, we've reported here today, we report to our workplaces, we have institutions like schools, okay, we have our other people, important people in the prisons, okay? This person will also be visited. This is according to our culture and the way of life. We have a lot of activities, so even if visitation, it's one of the activities, and we also come in conduct. So when you see, when we look for conduct, of course we have a tool which guides on who really qualifies for this to be a conduct, but ideally we look at activities around that individual. Then aside, you can see, at the end of the day, these people will report to a healthcare worker, okay? We love the lab personnel, we love our frontline workers, our points of entry workers. All these people are at risk of the infection. So I think this is the most important slide. Like we said, we are responding to an outbreak of Mpox, okay? So it's not a mass campaign. I think we've come to you when we are doing mass campaigns. Our routine systems sometimes inform which disease will need to scale up in terms of vaccination, and we do mass campaign. Mpox vaccination is not a mass campaign, okay? And then Mpox vaccination is not a rollout exercise, okay? We are not introducing a new vaccine, okay? We are responding, okay? So it is an integrated, including the other strategies. Remember, we were given case management, we were given surveillance, we were given infection prevention and control. Is that okay? Including those strategies in place, this is one of the key intervention we are going to include in this response. And it's targeted. We've given you a profile of who we've been guided, and our data has shown that they are at risk, okay? So this is an outbreak control response exercise. Thank you so much.
So colleagues, let's appreciate Kalani, Miss Kalani, in a better way. Thank you, Miss Kalani. So we are almost there. We're almost there, but we still have few things to do, and I'm glad my seniors are here. Dr. Grace is here, Dr. Sultani is here also. So as I said, we got a set of 25 questions prior to this meeting, and some of them have been answered. So if there are some that have not been answered, this is an opportune time for us now to open the floor. Let me ask one of us to pick the, Mercy, where are you? Oh, Dr. Nganga, please. Thank you, Dr. Nganga. So as we go to that phase, I'll be now returning back the baton to my seniors, to Dr. Sultani and Dr. Grace, to be able to moderate that section. And we have the team from the MOH, we have the 2 mics, so we'll be, just raise up your hand and please indicate which pillar that question you'd like it to be addressed to, so that can be a structured way of ensuring that we answer all those questions in a very good way. So with this now, allow me now to usher my boss, Dr. Sultani. Daktari. No, you moderate for us, because at that level now, we give you the honor. When they're asking questions, then we can be able to, if that is okay, Daktari. Good. Let's appreciate my boss as he comes in.
You're throwing me under the bus. Eh? Okay, so thank you, Limo, for this opportunity to be able to now open up the conversation, because I really want to just also share that this is not a one-way, it is not a one-way traffic, because as speaker after speaker has indicated, this is probably one of the most important engagements that we can have during a public health emergency situation. You know, getting our media, who are generally responsible for provision of information, to also understand the, you know, the response or the intervention, so that as we continue communicating, which is a very critical element of the response, we communicate it in a way that promotes the response. So it is not a one-way engagement. Indeed, it is an opportunity for the media. Yeah, that's why it is called a media engagement meeting. It is an opportunity for the media to now clarify some of the issues. And I think a lot of them have already been clarified. So before we go into any other issue, I think this is now an opportunity for us to give it back to the media. Let us hear from you. If there is anything that has been covered that was not clear, please feel free to bring it up so that it can be clarified. If there is an issue that you feel you need addressed, this is the time for you to be able to ask. And I just want to also tell you something, that us in the health sector, sometimes we operate like people who are closed up in a cocoon. So we start rolling out interventions, and then we think that everybody understands what we are doing. So when now we start reading things in the media which are not correct, which Leila was talking about, disinformation, misinformation, we start getting annoyed and saying, why are these people putting wrong information in the media? And yet they genuinely don't know what is happening. So this is a very important intervention to ensure that we are all on the same page, so that we can continue having, Leila has taught me today that infodemics are positive and negative. So today I want to see a lot of infodemics, but the positive ones, yeah? Positive infodemics, which a lot of, you said over what? Over abundance of correct information, you know, so that we do away with the wrong one, but we have the correct one. So the floor is open. I think we can start from there, and then we go to my comrade from the union, then we come to this gentleman here. We start with those three.
Asante sana. My name is Kennedy Odhiambo. I work for an organization called Masculinity Institute that is predominantly working on the wellness of men and boys in this country. One of the biggest surprises that I've had today is the statistics. And we don't want to doubt statistics, because you know you have the authority to give us data that is generated from the reports and work that you've done as a ministry. So the indication as at now is that 60% of the people who have tested positive for Mpox are women, and 40% are men. This is interesting, but you've also not told us that who is that person who died. I don't know if it is a woman or a man. That is important to us, because when we are programming, we also need to know, to tell on the level, the numbers of people who are succumbing to this kind of pandemic. But what is important to me also, or what is important to us in terms of men programming, is that the language of engaging men is completely different from most of the time what we are talking about. Even when we are talking about the instructions on what to do. If you look at the numbers of men who are dirty and don't care in this country, if we step out of this room, then you will realize that if you tell them go and wash your hands, that is not enough for them. If you tell them that don't engage in multiple sexual partners, that is not enough. Is there a plan that you have in place where you are going to engage in active and direct communication with men. I know that there's a deliberate intention to invite men through the men-dominated institutions like truck drivers. But what is the message you are telling them? Yeah, this is important to us. Or is there any opportunity for co-creation in terms of messaging and engagement? Thank you very much for the good work.
Yeah, so I know journalists like talking a lot, especially the reporters. So this is a question session. Now you have given us a small lecture. I have gotten your point. But let us not now start usurping the opportunity to make our own presentations. But I think that is well noted. We will come back to that. My comrade from the trade unions.
Thank you very much, and I appreciate the presentations. My question is a clarification question from the vaccine presentation.
Your name was who?
Karo Ndogo from Kenya Long Distance Truck Drivers Union. About the vaccines, they shared that priority will be given to populations at risk. So I just needed to find out, will it be given specifically to long distance truck drivers, and how they will go about that so that we know where to plug in. Thank you.
Very good, very good. Now that is a good question. Very short and precise. Yes, there was someone here. That is you?
Yes, thank you, Dr. Martin Lechero Hezron Nabiro from Kenya Red Cross. Mine will also be short and still on vaccine. They indicated that there will be a first vaccination approach, that is phase 1, phase 2, and then phase 3. In regard to phase 1 and phase 2, just to get clarification whether first approach will mean that we start with phase 1 and then go to phase 2, and then if that's if the case is that we started from phase 1 and then phase 2, my input to it will be like looking at the areas that we're really keen to cover or to address the control. I would suggest that probably if phase 1 and phase 2 runs concurrently. Thank you.
Okay, thank you very much, and thank you for being precise, because I want us to now give as many people an opportunity as possible. So we will pause with regard to collection of questions and address the ones that have already been brought up. So I know that I have a team here which is on top of things. So first is around the gender distribution. I want someone to make a comment on that. I don't know, that will be Michelle. So 60% are women, 40% are men. The one who died, was it a woman or a man? Tell us a bit more about that, and what is the plan for engagement of men, because sometimes we are a bit stubborn. So yes, over to you. You want to come up here? Please come.
So thank you very much for that question, which was asked by somebody from the Masculinity Institute. It's very positive that now we have organizations looking at the well-being of men and boys. That's a very positive thing. So I'll just quickly answer one part of the question about the person who died from Mpox. He was a 42-year-old male truck driver from Bungoma County, and he had another underlying condition that made him vulnerable and may have contributed to the death. So in very brief, about the messaging to men, please could somebody from the communication team take that, maybe Leila or Martini.
Martini, come and answer from here.
Thank you so much, Kenneth, for the question. My name is Wycliffe Martin, working for the Ministry of Health in terms of risk communication and community engagement. The question is, in terms of risk communication and community engagement, we have a whole plan in terms of capturing and targeting all the groups. And part of why we are here is part of the implementation of that plan. And so in the next 1 to 2 months, with support from WHO, UNICEF, IOM, and USCTC, we are implementing that plan in terms of especially reaching the high-risk population along the highway, the 14 counties, So this plan, we are going to reach all the high-risk population, especially the truck drivers, who majority are men, and also the sex workers. So we have a plan for those high-risk population, and I assure you that we are going to discuss with you, or now we can still collaborate with you, so that if we have not captured the best way to roll out our plan, then we can have an opportunity to revise it and be able to ensure that we holistically reach everyone. Thank you.
So, Martini, sorry, before you leave, I just wanted to find out, the masculinity, you're called Masculinity? Masculinity Institute, because we have a pillar on RCCE. Are they welcome to come and contribute to designing a way in which we can reach the males? Maybe, or they are not welcome? Maybe.
No. That is a great idea, and we welcome everyone. In terms of risk communication and community engagement, is a business for all of us. So masculinity, truck drivers, long distance, we have the sex workers, all of them are on board. In our last engagement in December, we engaged the youth, and then the Gen Z said, we are not here to read this business of hard copies, and that is why we are an extra mile of getting the QR code. So in terms of our messaging going forward, we shall have a QR code, whereby even for the truck drivers, we shall scan it on our lorries and you can get the message. Thank you.
Yeah, so I think what I want to really bring out is that this response is a whole of society approach. Everybody is welcome to be part of the incident management system. And this one I'm telling you as the incident manager. And once you get into the incident management system, you become an equal. There is no bigger person, there is no smaller person. So in the pillar, you contribute equally. So we do not have a monopoly of ideas. That's why we are looking out to ensure, and in fact, Martini's pillar, the RCCE, risk communication and community engagement, I want to see very many journalists, many members of the fourth estate contributing to best ways in which we can reach out to the population, because you are the professionals here, you know. So that one we really need to, and I think after this, let's find out, Dr. Ikahu, how they can be roped in, because I'm sure quite a number of our colleagues here would also like to participate. Now, the next set of questions was around the vaccine rollout. I think Rosalia, and you can see I have a very sharp team. Mpaka naona wengine munanisikilia wivu. My team is very sharp, so you can see how they are well on top of things. So Rosalia, tell us about the vaccine priority populations. You know, the populations at risk, truck drivers, how it's going to be done. And then you can even go as far as addressing the issue on the phases. Phase 1, will it come before phase 2, or we are going to start with the phase 3, then phase 1, like that? And if we are starting with the phase 1, then, you know, there were some issues that our brother from Red Cross wanted you to clarify. So go ahead.
Thank you. Thank you. Thank you, DDG. My brother from Red Cross, thank you for this very important question. Yes, the truck drivers are among the high-risk populations. And this we are not assuming. When Dr. Michelle was making her presentation, our epidemiological data points to this. And we have that data, they have been included, so they are part of that group. So we said the high-risk groups are people who are going to have direct contact with the cases, and mostly they are body fluids, okay? And also contact with cases who are already showing signs and symptoms. Those are priority. On the phases, remember we said that we are responding to an outbreak, okay? So the priority has been given to people who are already following who are already in this category of risk groups, okay? so that we can stop the outbreak. Okay? Those are the people we will give priority to. The other concern was how we are going to get them. The vaccine deployment plan, it's still being finalized, and we are going to work with you. We know this is a mobile population. We know this is a very unique population. We'll have to work with you. The Minister of Health might not comprehensively, as much as we understand the activities, be able to really have the hotspots and how we are going to map out and employ the strategies on how we are going to reach out to our long distance truck drivers. Remember, these are people who are moving, and maybe we catch them in Nakuru, the next day they are in Busia, the other day they are in Uganda inside. So we'll work with you because we understand the context better, and you'll be able to inform especially the strategy on how we are going to deploy this vaccine. On phase 2, running concurrently, I don't think our plan is to have the priority first. Then our epidemiological data again will also inform phase 2, because phase 2 is those people who are in danger of getting the severe form of the disease. This data from our surveillance will tell us, is it the people who are immunocompromised? Is the people with chronic illnesses? Who are these? Then from there, again, together we'll plan on how the phase 2 can be rolled out. Thank you so much.
Thank you. Sorry, Rosalie, we don't want you to break your foot now. Yeah. We have Hensa. Your name is very difficult, Hensa. Yeah. Hensa, maybe you can just rise up. I don't know if you had an opportunity to say something. Yes. Yeah. Hensa spoke here. I think you saw him, and Hensa is really helping us with being able to procure the vaccines. So we are hoping that we will be able to get some vaccines, but the quantities are very limited. So maybe, Ensa, you can make a small comment on that. I just wanted them to see you. And that's why we are saying this is not a mass campaign. It is a highly, targeted intervention where we will be using very small quantities to meet these particular. Speak from here. Just 1 minute. Okay.
Thank you so much, DDG. Rosalie have explained it very well. Vaccine is one of the complementary intervention. First, we will prioritize the risk groups, as Rosalie explained. Then we will create we will prioritize the other risk counties, risk population in general, to create a herd immunity among the communities. But the first target for this issue is because Kenya is strategically seated in the transport belt along east, southern, and central to West Africa. So the long truck drivers are the risk groups. We need to protect them. They are supplying all our commodities for our livelihoods. So we need to give them a priority to be vaccinated and protected themselves as well as their families. And also the other priority groups, the commercial sex workers and the others too. So that is the priority. Based on the current available vaccine, Kenya have allocated 10,700 vaccine doses to do. And as soon as we utilize those vaccines, other vaccines will be allocated based on the data will be available. And I believe that humans are the cause of all the hex. We humans are the cause of all the hex around the globe. So humans are also the solution. So vaccines are one of the key, especially very important element to stop outbreaks And please disseminate a positive information about vaccines so that we can protect ourselves, we can protect our families, we can protect our children and the risk groups. Thank you.
Thank you very much, Hensa. I hope ndugu zetu kutoka kwa media mumesikia hiyo. Najua sasa lazima pia mkae chonjo ndio musikie. Hensa is from Africa CDC and we are working very closely with Africa CDC to be able to secure the vaccines. That is, you are insisting, you want to ask a question? Or you want to make a contribution? Sasa ndio una bulldoze your question kabla hata nifungulie. Haya, go ahead. I think at this rate you might come and flash me off the come. You might come and flash me off the stage. Yeah. And then we will try to see if they
in the public health, and you do the prevention from the source. And according to the introduction, it was Mpox is transmitted between human beings and monkeys. And me, I come right from all the way western. We have monkeys and we have dogs and we have human beings. So during vaccination, the people concerned, have you put in place to do this from the source, which is the monkey and the dog, so that it comes to the human being?
Let us vaccinate monkeys.
The source, the monkeys are the yeah, so we have not seen any people from wildlife and people from the Nini to be involved, so that vaccination can be done.
Okay.
That's
thank you. Enda na microphone yako. No, Pio anakuja hapa kuleta stories za kuvaccinate monkeys. I know what he's saying. He's saying that he wants to see people from wildlife. They are part and parcel of the incident management system. Yeah? So, you know, this is just a media briefing meeting, Opio. And Opio, when you look at the statistics that have been presented, Kenya, we have registered only 36 cases. That tells you something about our response. Okay? Yeah, and I really want to, I just want to request that we give a round of applause to the team, because they have done a great job. We are still at 36. Tuwapigie makofi. We have registered, hence how many cases do we have in DRC? Is it upward of 15,000? Yeah, upward of 15,000. And when you look at the case fatality rate, we have lost quite a number of people to Mpox. But in Kenya, we have kept it at 36, and we have lost only one person. And we want to keep it that way. We don't want to lose any other person. So we are using a whole of, not just a whole of government, but a whole of society approach. So in our response, we have people from wildlife. Ikau, do we have people from wildlife and livestock in the task force, isn't it? Yeah, so we are involving all the sectors. Today is a media briefing, that's why probably they are not here. If we called all of them, then we would really need to have this meeting in Kasarani. Yeah? Okay, now I want us to take a very quick last round of questions. We'll start with that gentleman there. There is no other. So you give that gentleman, then we respond, we bring it to you, we close from there. Please go ahead. Introduce yourself first and where you come from.
Good morning, everyone. My name is Samuel Do Ouma. I'm a journalist. I write for Health Business Magazine. I have 3 questions. The first question is, considering that we have so many outbreaks, not only Mpox, which somehow share similar symptoms, and the outbreaks is like regionally. Do we have a regional response plan, maybe to just ensure that we are in the same page as a region to tackle this outbreak? The second question is on access to care, especially for the most vulnerable population, that is the truck drivers. As a ministry, what are the plans that you put in place to ensure that this mobile population can access care and also timely maybe testings and everything while they are doing their job? Because the nature of their job, they work with time, so they might not have time to go and maybe do those tests. And maybe the last question will be on communication. As much as we will be doing the target communication for maybe the males and the target populations, we also realize that it is a cross-border problem. And maybe these other guys that we are targeting might not be very fluent with our languages, that is both Kiswahili and English, which most of us are reporting on. Are there maybe plans to include even infographics as a mode of communication, so that somebody can look at the pictures and maybe just to know, like I saw that in the HIV response, that they're also using infographics to pass on the information. So those are my questions. Thank you.
Sasa umeturudisha mahali huyo jamaa wa Masculinity Institute alikuwa ametupeleka, but you saved the last, the very important question for last. So, response plan, regional, there is. At the Africa region, we have a regional response plan which has been done by Africa CDC, also with contribution. We also have a WHO, Afro region, who have provided a response plan for the region, okay? So we are even drawing down from those regional plans so that we can have a coordinated approach. By the way, whereas we have an incident management system here in Kenya, there's also an incident management system at the continental region. The Africa CDC has established one, and in fact, it's seated in the at the hotbed of the outbreak in Kinshasa. So is it Kinshasa or where? Ensa? The IMS, the Africa CDC IMS, is it operating from Kinshasa? Ah, good. And it is a combined effort between Africa CDC and WHO, isn't it? Yeah. So we have a regional response plan, which is actually guiding this. Number two, access to care. Do we have our case management team here? I saw Francis somewhere. These truck drivers, as they move around, how are you going to ensure that they access care and they continue working? I think you can come and address that one. Eh? Are there any plans in place to ensure that they get, because they are a mobile population, they get treatment? And then, Martini, you also become ready, because there is the issue of infographics, and probably he stopped short of asking whether we are going to translate into the languages of the truck drivers. Eh? Yeah. So maybe Nganga, as you consult, so that you can get the question properly, you can go with your question so that they be answered together.
Good morning. My name is Anthony Utua from Long Distance Drivers and Conductors Association. My question are two. Actually, there were three. One is sort of answered. One, the vaccine acceptability. How do we get the drivers to accept the vaccine? You remember we had the issue of COVID. Drivers were skeptical about the vaccine. Number two, there are issues of labor related, whereby when drivers, long distance drivers, they have Mpox and they report it. There's a spirit of getting scared of reporting because they may end up getting sacked. So we have in place some policies that can protect the drivers on such issues. The third one, thank you. I think that's enough for now.
Okay, these ones of yours are hard. Aya, Nganga, Kuja.
For a minute?
Okay. Oh yes, I was looking for you. I thought you had gone.
No, yeah.
Because I wanted, after this we go and discuss. You usually intimidate us on the road with your big trucks. So I wanted to find out how we can work out so that with our small vehicles you don't come with a very loud horn. Eh? Yes, ask your question.
Okay, I'm just adding on what you're saying.
Yeah.
We have a case where a driver was laid off because he was taken to quarantine in Busia. So such cases, how are we going to deal with?
Okay, thank you for elaborating on that part. I was having a bit of a problem understanding why you would sack someone for being sick. I was trying to wrap my finger around it, but it is related to quarantine. So when you are in quarantine, you lose out on work and then you are fired. Ah, okay. Aya, Nganga, ulikuwa hujafika? Kuja bwana. And then Martini, eh? Martini has run away. Ah, okay.
Thank you, DDG. I will take the first question. For along the corridor, we have wellness centers that are able to sensitize the truck drivers. They are also able to detect, report, and respond to the Mpox outbreak as it, if and when it presents in these wellness centers. The wellness centers are, we have one in Maimahiu, we have another one in Mlolongo, and we have another one in Naivasha. And then we have equally sensitized the staff who work in these wellness centers, and our points of entry staff have equally been trained on the detection of these Mpox cases. So if and when a truck driver presents in any of these facilities, they will be well catered for. And then the IEC materials have also been distributed along the way bridges, and I think the truck drivers can attest to that they do have access to these IEC materials. On the quarantine issue, the main advice by the ministry is that we try as much as possible to isolate the cases. Those who have been detected to be positive are the ones that are being isolated, so that we limit spread, especially community spread in our population. And through this, we have been able to curtail the number of cases to the current 36. Otherwise, we would be having a lot more cases than we have currently. Thank you very much.
Thank you so much for your question in terms of communication. Number one, in terms of involvement of within the country and other countries, we work with regional structures, East African Community, and then we will also work with the East African Regional Coordinating Center for African CTC, and we have established, and we use the same resources as much as possible. We try to adapt the resources which are used regionally, so that whenever truck drivers and other commuters cross between one border to another one, they can appreciate these messages and they can use the same. And that's why we try also to use as much as to use infographics, because that's what our population can learn more and appreciate. And in this also, with using WHO and UNICEF, we have the AIRA. AIRA is one of the platforms whereby we collect information, what is being said outside there. So it's a platform whereby we collect information routinely, including the languages. Number three, within the country, we have translated our messages into 7 languages: English, Kiswahili, Kamba, Luya, along the transport corridors, among the vernaculars along the transport corridors. We are using the local radio spots and TV spots, and then we are going to translate some of our IEC material in the local. For vaccine deployment and acceptance, we have a communication plan for which we shall use to deploy the vaccine. And all of us, we are key influencers, and that's why we are here. You are our ambassadors now, that you are going to support us in terms of that time when it comes to deploy the vaccine. We notice Kenya truck drivers, sex workers, we have the masculinity guys, we can work together and then we ensure that the vaccines reach the intended goal. Thank you.
Thank you very much. Now I think priorities have started changing. I really want us to now bring this to a close. After having a lot of information, a small infodemic here around the Mpox response. So before I call Tabitha to come and pray, maybe Nganga, you are the one who will give the vote of thanks. Okay, ngoja kidogo, I'll just call you so that we can also allow the media people to go and start packaging some of this information to be able to share it with our populations. Let me take this opportunity to really thank all of you for making it to this particular meeting. As I said before, I consider this to be one of the most important engagements within this response. You will realize that Mpox has been declared a public health emergency of international concern by the World Health Organization. It has also been declared as a public health emergency of continental security by the Africa CDC, the Director General of the Africa CDC. And I am privileged to be among the Africa CDC's emergency consultative group, which advises the Director General on such decisions. And so far, we have not yet gotten to the point where we feel that this public health emergency of continental security can be declared over. The World Health Organization has also not declared the public health emergency of international concern to be over. So we are still in this, and that is why we really need to drive this process forward by making sure that the right information is being disseminated out there. So I consider this to be very important, and I hope that moving forward, we are going to see much more positive engagement within the communication circles with regard to making sure that the right information is being passed over. So after the final prayer, we are going to have a group photo. So I just want to welcome Dr. Nganga, so that you can come and give us a vote of thanks. Then Tabitha can come and pray for us. Then we'll just assemble in front here and have a group photo, which will be at least evidence and the proof of the fact that we met today. So thank you very much, ladies and gentlemen, and God bless you even as we finish this meeting. Karibu sana Nganga.
Thank you, DDG. All protocols observed. I want to start by thanking the ministry leadership led by our cabinet secretary, our principal secretary, our director general, our deputy director general, and I also want to convey a special appreciation to our director, public health, Dr. Grace Ikahu, for their great commitment towards our response activities, including this Mpox response activity. I also want to take this opportunity to thank the representatives of partner organizations, including the World Health Organization, UNICEF, IOM, CDC Africa, US CDC, Red Cross, our religious leaders, the Council of Governors, amongst others, for gracing this occasion. I appreciate other stakeholders, including the Kenya Truckers Association, long distance drivers, for your continued support and commitment towards this response activities. Special thanks to the Fourth Estate, because it is through you that we are able to convey our messages as far as the outbreaks are concerned. And I want to especially thank you for being with us throughout the Mpox response activities. I want to thank the presenters who have done a great job. I know they have been having sleepless nights just to prepare for this occasion, and really whatever it is that you have been able to present to us, whatever it is that you have been able to present to us will go a long way in protecting the country against this illness. I also want to appreciate the hotel for the great work that they have undertaken to have us well catered, and we have been comfortable throughout the meeting. Lastly, I want to thank everyone for finding time to attend this media briefing meeting and for making this a great success. Asanteni sana, Mungu awabariki.
Good. So, ladies and gentlemen, let's appreciate ourselves for the good job. Then, kindly requesting the DDG, Dr. Grace, all our partners to be at the front as we take the group photo. All our partners, DDG, Dr. Grace, please, it's our time now. And our partners, start moving. Start moving. Start kindly. Then, remember also the Fourth Estate, your partners. Please kindly join the DDG. We're almost here now. I think we can use the podium here.